All right, so you've made it to the last lecture in dental emergencies. And for this lecture, we're going to be talking about a few things that are not in our book and then HIPAA that is in our book. But we're going to start off talking about dental trauma. So, patients that have come into your office with trauma emergencies, and also child abuse and neglect. And then we're going to finish out with HIPAA compliance and a review of how to complete a medical history form. Dental trauma not only refers to the teeth themselves, but also any place around the face or mouth. We're also especially concerned with the lips and the periodontium as well as the teeth. So sometimes we can have dental trauma that's very localized to the soft tissues around the face and lips, and that can be either sutured by a plastic surgeon, an oral surgeon maybe in the emergency room, or it often can be sutured in a private practice by a specialist such as a periodontist or an oral surgeon. If it involves the teeth, we might be looking more towards a general dentist option, but it also doesn't have to. Just because there's trauma doesn't mean it includes the teeth. Unfortunately, these traumatic incidents are often young children's first trip to the dentist. If you think about the terrible two stage, one of the first things that they talk about is trying to avoid any sharp corners of a coffee table when children are lifting themselves up on the coffee table, and it's very easy for them to fall and hit their face on the corner of a coffee table. So that's something that a lot of mothers and fathers are aware of, but it is something that happens rather frequently. Usually it doesn't result in much damage. It's also important that you have an accurate review of the dental history. If there is repeated issues with trauma and trauma to the face and teeth, that might be indicative of potential child abuse and or domestic violence. So it doesn't have to be only in a child that we're looking for repetitive incidents of this. And that's something we'll touch on child abuse here in a few slides from now. Often these dental traumas are accidents. They're unexpected and unpredictable. So as dental offices, anyone in the dental office needs to be trained and know how to best handle a emergency when it walks in your door. Someone's going to be calling in, and they're going to need to get in quickly, and they're going to need to have attention quickly because with a lot of these incidences, time is of the essence. And you can imagine if you have a young child involved, there's already a lot of stress with the child being in the accident, maybe coming to the dentist for the first time. So we need to be able to really handle the emergency as quickly as possible. When you first get a person in with a dental injury, the first thing you're going to do is just do an overall physical assessment. Sometimes people come into the dentist and think that they just have an issue with their mouth, but there could be a non-dental injury that would be more serious. So something like a concussion, you might want to ask if they ever lost consciousness and how long it took them to regain consciousness if they did. Make sure that they're showing all signs of they're showing good signs of no neurological damage, so that you're going to assess their eye opening, their verbal responses, make sure they're responding with you, and their motor ability. So are they able to follow your pen with their eyes? Are they able to respond and shake your hand? After we do that, you're going to go with an extra oral assessment. So first we want to just clean the face. If there's any blood or residual dirt, if they fell, clean their face and the oral cavity inside with water or saline. You could use a mild detergent on the extra oral tissues, but you just want to make sure you clean it up and so that you can really make a good assessment of what the damage is. And you also want to try to make a shortened medical and dental history. So we talked about, knowing the dental history and if there's any repetitiveness of the traumatic incidents. But you also want to make sure that you're going over a medical history in a short, brief form so that you can get to the emergency as quick as possible, but you're not taking 10 to 15 minutes to fill out a whole medical history form. So really what we're going to be looking for is, does the patient have any allergies? Do they have any health conditions? Do they have any health disorders? Do they need to take a pre-med? So you're going to be asking any of the questions that might necessitate them taking a pre-med. Ask about any previous traumas. Anything basically that would influence how you would proceed with your treatment is what you're going to be trying to find out in a shortened form so that you can get to the emergency as quickly as possible. Next, you're going to be going inside the mouth and completing your intraoral assessment. First, you'll just start with a visual exam, and you just want to identify what kind of injury may have there been and what's the extent of that injury. So can you visibly see a tooth that was fractured? Can you visibly see that there's a tooth that was knocked out of position, or a tooth that might be lost completely? You can use your mirror. I believe we talked about in one of our first times in preclinic when we first learned how to use the mirror, how to use transillumination. And that's when you reflect light from behind the teeth and you reflect it through the teeth. And that can reveal if there's any damage to the pulp of the tooth, and you can identify if there's pulpal hemorrhage, so there's bleeding of the pulp, and you can kind of see that by when you do that transillumination, you'll see a redness coming through the tooth. And then you can also use palpation, just with either 2 fingers or the blunt ends of 2 instruments, and that'll help you determine if there's any mobility of the teeth and what degree it would be. Some things you don't want to do, at this point you might as well just postpone any pulp vitality testing, and what pulp vitality testing does is decides if the nerve of the tooth or the pulp of the tooth is vital and alive. And we're just postponing this because right now we're in a post-traumatic stage, and it's not really a definitive diagnosis, so we're gonna bypass that stage and do other assessments to decide how we're going to treat the emergency. And finally, a lot of dentists like to use percussion to test the vitality of the tooth as well. And that's when the dentist, if you've ever had a dentist tap on your teeth with an instrument, and they'll say, does it hurt when I tap? And they'll tap a couple times. We want to avoid this. There's not going to be much diagnostic value in this circumstance, and doing so may exacerbate the existing trauma. If there's already a fracture of the tooth, we don't want to be putting any more force on that tooth. So we're going to move on to a radiograph assessment. When someone comes in with a trauma, we always want to try to get a radiograph, and depending on the age of the patient, the severity of the injury, what kind of injury they sustained, if it was just a blow to the 2 front teeth versus a huge blow to the jaw, it's going to dictate what kind of radiographs that you want to take. So if the patient is a small child, and you guys probably have heard this from your radiology course, you might do something like an occlusal film. So if the maxillary arch was involved, you would just take an occlusal of the maxillary arch, and that's because PAs on a young child are very difficult to get. If it's a very small area, just affected by the blow or the injury was just localized to a very small area, you might take a periapical radiograph just of that small area. If it was something where the patient took a blow to the jaw, or they fell and their jaw was included, you might take a panoramic x-ray. And also, in the upper right-hand corner, I have a picture, and that's actually a screenshot of a CBCT scan, which is basically a 3D x-ray. And that will show a lot more information than just our 2D x-rays. So if you're unsure of what the extent of the damage is in just a normal 2D periapical film, you might also take a CBCT scan or or the 3D x-ray to get a better idea three-dimensionally what's going on with that tooth. So you can see in the upper left-hand picture that looks like it's 8 and 9, and they took some kind of blow to the face because right mid-root, both of those teeth look like they're completely fractured, a vertical root fracture. And unfortunately with that, those teeth would be hopeless and need to be removed. In the picture on the upper right-hand corner, that screenshot of the 3D x-ray, you can see how the tooth has been injured and moved out of place, and there's a space, and that's what that green line represents. Here, I'll show you that green line right here. This space all through here is damage and movement of the tooth out of the socket, and it looks like here is the lingual and here is the buccal or facial area, and the tooth has been moved and moved out from the lingual space towards the buccal, and it looks like there might be a fracture of the bone as well. And then finally, in the bottom panoramic x-ray, I don't know if you guys have been looking at this, but there is a jaw fracture that is pretty obvious in this x-ray, and I'll show you here. Here it is. So they took a blow to the face, and it looks like there's some kind of fracture here. Now this is again a 2D x-ray, so we can't necessarily know the complete extent of this, but it's a good, pretty significant fracture there. And also here, if we notice what this is, behind the lower anterior teeth, it's a lingual bar from orthodontics. Alright, so radiographs are always going to be taken when there is any kind of trauma, so that we can determine the extent. There's a few different terms and vocabulary terms and definitions that I want you to know for the type of trauma that a patient can experience. So we'll go into these in brief, and we're also going to go through each of them. So the first is subluxation. Then we have luxation, which includes both extrusion and intrusion. And then we have avulsion, which is complete displacement of the tooth, so the tooth is lost in this circumstance. And then we have crown fractures, and it can be either a minor crown fracture or a major crown fracture. The first term I want you to know is subluxation. So when we break that word down into subluxation, the prefix sub means under or below, beneath. Luxation. So this is not going to be complete luxation, it's just below it. So when we talk about the other word, just luxation, this is how you can distinguish them. Sub means beneath. So this is when there's an injury to the tooth, the supporting structures of the tooth, and it only results in increased mobility, so there's a little bit of movement to the tooth more than before it was injured. And there's no displacement of the tooth. The tooth is in the same place. It didn't move out of the socket. It didn't move, in towards the socket or out of the socket. There's no displacement. The only thing that you will see with this, other than the increased mobility, is bleeding from the gingival sulcus. So when this is a rather light hit to the face and the tooth does not move, there's a little bit of trauma to the periodontal ligaments. So if the ligaments are stretched a little bit, that's what's going to cause your increased mobility and the bleeding. And on an x-ray, this tooth is going to look pretty normal. You're not going to see any evidence of the trauma on the x-ray. So if a tooth is subluxated, the dentist may choose to treat this with a flexible splint, where they splint the adjacent teeth to that tooth to help it stabilize and tighten up those periodontal ligaments. They may just say, eat a soft diet for a week and let's reevaluate, and be very conservative. There is the potential down the road that this tooth might need a root canal just based on the trauma that was done to it. Without the prefix sub, now we're just talking about luxation. So now luxation is the dislocation or displacement of a tooth from the socket. So when the tooth is displaced, there's going to be fragments or a fracture of the either the labial bone or the palatal or lingual bone, depending on what area you're talking about. So if we look at the pictures on the left-hand side, you can see, unlike that first picture of subluxation when there wasn't displacement, we can see that this tooth from the occlusal view, the bottom picture, that the tooth has been displaced to the lingual. Can you see that? So it used to be right in line here, and now the incisal edge is more towards the lingual. If you look at the pictures, the diagrams in the middle, you can see on that middle picture here that the root has gone more palatal, leaving that space behind on the lingual where the socket is, and you can see that there is a fracture of bone right at the labial alveolar bone. And then on an x-ray, you're definitely going to see some evidence of trauma. This x-ray here was a great example of luxation. So you can see that the tooth in a 2D x-ray, you can't really tell if it's buccal or lingual. If, obviously looking at the patient, if the crown is still supragingival, you can see which way the crown is facing. Is it facing out towards the buccal or to the lingual? But this 2D x-ray, it's much more difficult to determine buccal lingual, and that is where the slob rule comes into play with you. That if you've learned the slob rule, I'm sure you have already in radiology. Extrusion and intrusion are two terms that fall under the category of luxation. So we're still talking about a partial displacement of the tooth. The tooth is displaced out of the socket, but now we're talking directionally, which way it's been displaced. So if a tooth has been extruded or it has extrusion, the displacement is the tooth out of the socket. So the tooth has come more coronally or out of the socket. So you can see in the real picture there's bleeding at the sulcus, but now you're seeing a little bit of root structure because the tooth has been pulled out. And it's very evident on the radiograph. So the tooth is now longer than the adjacent teeth, and at the apex you can see how it's been extruded out of the socket. And then intrusion is just the opposite. It's when the displacement of the tooth is into the alveolar bone. So if you think about this, you can think of the tooth being pushed up. So on the real picture on the right-hand side, the tooth is shorter than the adjacent teeth because it's gone up into the socket. You can see here in the x-ray, it's not as obvious on the x-ray, but you don't see any displacement out of the socket, but you do see that the crown height is much shorter than its partner here, number 9. And then it's not as obvious in the diagram, the pictures, because we're going into the socket. So there may be fractures of the socket and the bone, depending on the severity of the intrusion. So this actually happened to my sister when she was very young. I would say she had to be under the age of 6 because it was her primary teeth. Unfortunately, my dad was taking her on a 4-wheeler ride, or as you fancy New Jersey people like to call them ATVs. He was taking her on a ride and they hit a bump and she hit her face off the handlebars of the 4-wheeler. So her teeth were intruded all the way. You couldn't even see them. My dad actually thought that they were completely knocked out or avulsed, like we'll talk about soon. Took her to the dentist, and they actually just let the teeth, they took an x-ray, saw that the teeth were still there, and they just let the teeth naturally erupt back on their own, and that's what she did. And thankfully she had no damage to her underlying permanent teeth that were already developing there. So it was the best situation we could have had for a mistake that my dad always is embarrassed to tell the story about. Okay, so finally we have avulsion, or what a lot of people call when a tooth is knocked out. In avulsion, the tooth is completely displaced out of the socket, so there's no tooth remaining in the mouth. It's either in your hand or on the ground, or you can't find it. So clinically, when you look at the patient, the socket is going to be empty, and it could be filled with coagulum or just a big clot of blood and debris. So on an x-ray, obviously, there's not going to be a tooth present, and the major emergency that we're going to be talking about on the next slide is how do we handle when a patient comes in, or how do you tell someone to handle an avulsed tooth. When a tooth is avulsed or knocked out, our biggest thing to remember is that time is of the essence if you want to save the tooth. So first, you want to pick the tooth up by the crown only. You do not want to touch the root. The root of the teeth have vital periodontal ligaments, and we don't want to mess with them at all. Only if the tooth is extremely dirty. So that means, if it came out on a baseball field and it's covered in sand and the sand's caked onto it, only then do you want to gently rinse the tooth with water only. You don't want to use any kind of soap, no cleaning agents, and you absolutely do not want to scrub the tooth at all. It might seem gross that it was on the ground, but that's a definite no-no. And if it's not that dirty, the best way to quote unquote clean it is just put it in your mouth and use your saliva to clean it. Your tooth is used to the biologic nature of your mouth, and that's what it's going to be most compatible with. If it is possible at the time, if there's no obvious fractures of the bone, and you can do so, the best treatment is to re-implant the tooth into its socket as soon as possible and go seek dental treatment immediately. If for whatever reason you cannot reimplant the tooth, maybe the child is not being cooperative, or the socket is so fractured that you cannot reimplant the tooth, you want to keep the tooth warm and moist in the mouth. So the best way is to just put the tooth in their cheek, if the child's old enough to cooperate, and hold it in their cheek and don't mess with it, so that you can try to keep those periodontal ligaments viable. The longer it stays out of the mouth, the greater the chance that those periodontal ligaments will not regenerate and reattach to the alveolar bone. And the other thing to remember is we're not going to reimplant a primary tooth. So if it's a child that has lost ERF, we're just going to be taking them to the emergency room, the emergency dentist. Reimplanting a primary tooth could potentially cause harm to the underlying dentition if it's not done properly. Alright, so our last dental trauma is a crown fracture that can be either minor or major. So the biggest differentiation between minor and major is that a minor does not involve the pulp, and a major fracture involves the pulp. So a minor fracture can be contained to just the enamel only. If it is an enamel only fracture, that will be treated usually by just recontouring the tooth, or smoothing off the rough edges. If the patient needs a desensitizing agent, something like fluoride or another kind of desensitizer can be applied. If it involves the dentin as well, an enamel dentin fracture, still a minor fracture as long as it doesn't involve the pulp. The dentist might apply something like calcium hydroxide. That's something that will help protect the pulp, and then cover it with a restoration. Most likely, if it's in the anterior, a composite or white resin filling. And then if it is a major crown fracture, If there's enough tooth structure present after the fracture, if it's fractured completely to the gum line, it might not be an option. But there's most likely a major crown fracture is going to need a root canal. Um, they're going to have to get their root canal with medication to completely kill the nerve of the tooth, and then a permanent restoration would need to be placed, and most likely this would have to be a full coverage crown, or in layman's terms, a cap. But if there's not enough tooth structure present to hold a crown onto the tooth might be hopeless and need extracted. With crown fractures in mind, it's always a good time to remind people of things to avoid. So if you see anyone over this holiday season trying to use their teeth to open, I think that's definitely a soda in his hand. I would advise that person not to do that. That could definitely result in a crown fracture and potentially worse. And I've definitely seen a lot of people do that in my day. So please advise them not to do so. And also, I did a shout out to my dad in this lecture, so I'll bring my mom into it as well. An embarrassing story for her. It was last Christmas around this time. She was hanging up some Christmas ornaments and was putting little nails into our wall to hang the Christmas tree or Christmas decoration. And she put a hammer in her mouth because she didn't have enough hands, and she has veneers on all four of her front teeth, and she chipped three of them. She fractured three of her crowns because of the hammer in her mouth. So, another thing to avoid would be don't put hammers in your mouth, and basically don't put anything in your mouth other than food is a very good standard to live by. A lot of times when a patient comes with a dental trauma injury, it's also a sports-related injury. So when you have a risk assessment in your office, it should include questions regarding their sports history and sports activities. So this will help us determine their risk of having a sports-related injury or dental trauma. A lot of times mouth guards are recommended for protection from sports injuries. A lot of athletes don't choose not to wear them, and they'll complain that they interfere with the breathing, they interfere with their speech, they're just uncomfortable, or that they cause gagging. And if the mouth guard is properly fitted, we really shouldn't have those complaints. There's many types of mouth guards, and as you go through that list top to bottom, they're better at having a proper fit. So the first type of mouth guard is a stock mouth guard. This is something that you just go to the store, you buy off the shelf. It has nothing to do with your mouth. It's just kind of a average person's mouth, and it goes over the teeth, but there's no customization at all. It has nothing to do with how your teeth are. And the second is a mouth-formed mouth guard. Again, you're going to go to the store and you're going to buy this, but this is what people often refer to as a boil and bite mouth guard. So this is where the mouth guard is made of some type of plastic that has some moldability to it. So you boil it in water, it becomes soft, and then you bite down on it from your mouth, and it custom forms to your mouth. Now, it is not, if you have a really small mouth, you might have a lot of excess material, and that's not custom to you. It's the size of it's kind of a one-fits-all, but it also is going to form a little bit to your teeth. So the mouth formed is one step above the stock, because at least you have a little bit of custom. And finally, we go to the third one, which is a full-on custom fabricated mouth guard. And this is where at the dentist office you take an impression, or someone takes an impression of the teeth. A mold is made of the teeth, and the mouth guard is formed completely custom to that person's mold or that person's study model. So Obviously, your custom fabricated is going to be your top of the line best. It's going to be the most comfortable and interfere the least with the breathing and speech issues. So you're probably going to get your most compliance with a custom fabricated mouth guard. But if you go from top to bottom, from stock to mouthform and fabricated, custom fabricated, you're going to also increase your price. So, you get what you pay for in the terms of mouth guards. So if you can afford going for the custom fabricated, it's going to be your best protection and your best compliance. There are some follow-up questions that should be asked if a patient comes in with a dental trauma. First, we want to know where, how, and when did the injury occur. Where is going to help us determine, did it happen in the home or on the baseball field? We want to know. That might have some legal implications if it's happening at home. We also want to know how. Did the patient just run into the refrigerator, or did it happen again on the baseball field? And when did it occur? When is going to help us determine what kind of treatment is available at this time. Has it been too long to save the tooth? We also want to ask if there was any period of unconsciousness. Because this is a potential head injury, we want to check for those signs of any kind of brain damage, if the patient had any amnesia, if they had a loss of unconsciousness. We want to know if there's appropriate eye responses. If not, and if there was a prolonged period of unconsciousness, the patient may need to seek medical attention rather than the dental attention can come later. We also want to see, is there a disturbance in the bite? If we can't detect any dislocation, sometimes patients are very sensitive in their bites, so sometimes they can detect more of the dislocation or a fracture of the jaw if they're not closing the same way they used to close. And finally, asking if there's any hot and cold sensitivity. This is going to help us determine if there's any exposed dentin or if there is pulp damage potentially. So we're going to move on to child abuse and neglect. And this is going to be a quick little tidbit on child abuse and neglect, but basically dental professionals are in a great position to recognize and report child abuse and neglect, and that's why we are we want to educate you on knowing the signs and being able to make the mandated reporting to the appropriate places. And you guys are going to have a great lecture your senior year, a full lecture on child abuse neglect. So this is just kind of getting you the background or the base level knowledge to be able to know about that in the future. So there's a lot of children that are affected by abuse and neglect. About 75% of the abuse involves the head and neck, and the mouth is a common site. So again, dental professionals, this is our bread and butter. We're always looking at the head and neck and the mouth. So if we can see the signs, then that's going to be able to allow us to report and get these children the help that they need. So the mouth is a common site, and you can think about why that might be. Speaking, crying, everything that might annoy a potential abuser comes from the mouth. So that's why the mouth is much more common and the head and neck are very common. I do want you to know that it is a duty and legal responsibility of a dental healthcare professional to report child abuse. So by being licensed as a dental hygienist, you have the duty and you have a legal responsibility to be able to recognize and report this. So this is where the hotlines are. There's a national child abuse hotline that you would report, and there is a New Jersey child abuse hotline. And it's important to note that these hotlines are anonymous, and you can report something even if it's just a suspicion. You don't have to worry about, if something needs to be investigated, they'll investigate it. But you don't have to worry about the potential that you're looking into things too far. They want you to report any kinds of suspicion. So we're going to talk about some of the signs that you'll see. So the definition of child abuse and neglect. So it's not only just abuse, but it's also neglect. So the first part of the definition is any recent act or failure to act on the part of a parent or caretaker which results in death, serious physical or emotional harms, sexual abuse or exploitation, or an act or failure to act which presents an imminent risk of serious harm. So, again, it doesn't have to be something that's done to someone. It can be a failure to do an act. So, obviously, if you can think about child abuse and an act that could be done to someone, that's going to result in physical injury. This could be bruising. This could be scarring. But it also could cause an act that causes emotional harm. So this could be verbal abuse. But a failure to act, and this is where the neglect part comes in. So if a parent or caretaker fails to act and fails to do something, and that as a result, it results in their child being at a risk of harm. So when we see neglect in the dental office, it's where a child has severe rampant decay, and the parent has been told about it and not done anything about it. Or they have not taken their child to the dentist and they're running around with rampant decay, they're running around with abscesses, they're in pain, and the parent is not taking the appropriate steps to get them help. So that's where the neglect comes in to the child abuse. So this, the definition applies to parents and also caregivers, and child in this circumstance is anyone younger than 18, or as long as they're not an emancipated minor, so someone under the age of 18 who's applied for emancipation. Alright, so here are some of our red flags. So like I said earlier, we want to make sure that we're keeping an accurate dental history and we're keeping an accurate log of incidences of trauma. So if you have those repetitive injuries to the head and neck, or that neglect of dental care like I talked about, that's going to be a red flag for you. If there is an injury, those questions that you're going to be asking, the where, when, and how, they should be answered completely by both the child and the parent and or guardian. So the child should have no hesitation in telling you what happened, and also the parent should have no hesitation. They shouldn't be wondering why you're asking them all these questions. The child shouldn't be acting scared to answer your questions. And both the parent and the child responses regarding that injury should match, and that's a typo on that slide there. Instead of parent/guardian, should say parent/child responses should match. So if you ask them in separate rooms, did they give you the same answer? And finally, there might not be any physical signs of abuse, but if you have a behavior such as the child not making eye contact, if they're very jumpy, especially when you go to touch them even without any kind of instruments, if they just seem withdrawn, that's a little bit harder to identify, especially since they're in the dental office and they might just be squirmy. There's a lot of squirmy young children out there. And then if you see pattern injuries or something like ring marks from hitting, belt marks, if they have a lot of excessive bruising or cigarette burns anywhere, and we'll see a couple pictures on the next slide about that. So the top picture of the boy there, it seems that he is shrouding away and scared of someone just doing a simple touch to the head and neck area. A patient might often not want you to touch them because, we're in the position of being in a dental office that's scary to them. But in a normal situation, a child shouldn't be doing that. In the upper right-hand picture, there's a cigarette burn, and this person is measuring it so that they can identify that and see if there's any repeated incidents of that. On the lower lower left picture, there's bruising on the legs if a patient comes in with shorts on, and there's bruising everywhere. On the lower right hand side, there's bruising on the arms. So when we think about, why are we doing this extra oral exam? Why are we looking at the patient's neck? Why are we looking at their ears? This could be a good way to get yourself in the habit to look for these kinds of things. Yeah, we might not always be able to see the legs and arms depending on what the person's clothes have on, but if we roll their sleeve up for taking their blood pressure, you might be able to see something that they didn't want you to see, or their significant other or parent or guardian didn't want you to see. And then finally, in the middle picture there is a good example of what neglect might look like. So this person obviously has a lot of decay in their mouth. They've probably been in pain or have had pain, and maybe they just took over-the-counter medication to treat it, but they did not have the dental care needed to fix that. And this is a case of, the caregiver can't say, well, I didn't know. Their teeth are completely decayed to the gum line. They don't even look like they have any lower. Actually, that's actually lower teeth. It's not. It depends. Depending on how what image we're looking at is actually a mirrored image of the lower teeth there. But the parent can't say, I didn't realize that the decay was that bad, when it's obvious to anyone outside of the dental field. Alright, our final topic of today is HIPAA, and HIPAA stands for Health Insurance Portability and Accountability Act. So HIPAA is spelled with 2 A's on the end, not 2 P's, and that's a common mistake people make. So I want you to know what HIPAA is and what the acronym stands for. It was established in 1996, so not too long ago. And initially, it was established to protect the privacy of insured people and make it easier and more affordable for them to obtain health insurance. So what HIPAA did was prevent insurance companies from looking into people's previous medical histories or health information. It prevented them from seeing how many times in 1992 did this person go to the emergency room, because what that would do would cause them to spike the insurance rates because if they had pre-existing conditions, or it would say that they're a risky patient and that's why that their insurance was more. It's kind of like when you drive a car and if you have a lot of accidents, your insurance goes up because you're a risky driver. And then in 2003, they updated the regulations, and this was more about protecting patient privacy from others. So now we are prevented as healthcare professionals from giving information about our patients to other people without written approval from that person. The only exception to this is in the case of an emergency. Someone's unconscious. We are going to give them any health information that we have about them because this patient is in an emergency situation and the doctors need to know. Dental offices also must give written policies to the patients outlining how the procedures that they do to protect their personal information, and they must obtain their signatures about this. So the office must say how they keep the patient's information secure, whether that is if they're using handwritten charts and that are kept away from other patients and locked out of the ability for other patients to look at them. If there are electronic records, how does that office protect the security of electronic records? And that's what dental office have to provide that in writing to a patient. So at the dental school, you'll see paperwork in the charting about HIPAA. It's not something that you guys will be taking care of. It's the reception will be giving the forms to the patients, but it is something we do have here at RCBC. Here's a quick overview of what HIPAA allows us to do and what HIPAA does not allow us to do. HIPAA does allow us to call out the patient's name in the waiting room. Because we're not giving any other identifying factors about why the patient is there, we're allowed to just simply call their name, first and last name, in a public space and bring them back into the treatment area. You are also allowed to have a sign-in sheet. This is where the patient will come in and they'll sign in that they're there, and I'm sure you all have done this at your dental office, or probably medical offices more likely, as long as the sign-in sheet does not contain any other information other than just the patient's name. You must ensure privacy of your conversations within the office. So the office must be set up so that, if you're having a private conversation with someone, that someone in the office or next door can't hear that conversation. And if you feel like that is the case and someone could overhear a private conversation, the best option is to try to take that person to somewhere that is more private if you're having a serious health conversation with them. If there's charts, like I said, they should be stored away from public view. Any identifiable markers on the outside of the chart, there shouldn't be any identifiable markers on the outside of the chart. So that's why when we put the medical alert sticker there, it's just going to be blank, and any explanations are going to be inside of the chart. They used to have social security numbers actually on the outside of charts, and that's something that's now become a no-no. And then finally, if permission is given by the patient, you are allowed to disclose information, but you are only allowed to disclose information about the client to what degree is necessary to accomplish a purpose. So if the patient gives you permission to discuss with a referring dentist or a dentist that you're referring them to about tooth number 3, you should not be telling them about their plaque control at your last appointment or their something to do with a different tooth. We're only talking about the one tooth in question, and that's what the patient has permitted you to disclose. And the don'ts of HIPAA. So HIPAA prevents you and prohibits you legally from discussing a patient's treatment with any other person or healthcare professional that's not involved with the patient's treatment. So if you and your dentist are talking about your patient and their diagnosis, you are allowed to do that because you are both healthcare professionals that are involved with their treatment. But you are not allowed to discuss your patient's treatment with your classmate that has nothing to do with that patient's care. You're not allowed to discuss your patient's treatment with your boyfriend or girlfriend or husband or wife at home. And you're not allowed to discuss that patient's treatment with really anyone other than someone who's directly involved with the care, and unless the patient gave permission for you to speak with someone else about that. You are not to discuss patient care in a non-private area, so something that can be heard by others. So if you and your dentist are talking about the patient in the waiting room, that's not okay with HIPAA. You need to be talking about a patient's treatment in private. Here's a big one. You should not post anything patient-related on any social media platform. I don't care what kind of information it has, even if you think it doesn't have identifiable information. You need to refrain from posting anything on social media. You can get in a lot of trouble. Social media, even when you think it's something that is not permanent, it's permanent. Even if you think you're in a closed group, someone can always take a screenshot of something that you said and report it back to authorities. So You need to make sure you're very smart about how you use your social media, and I'm very passionate about social media professionalism. So the only time that you can post anything on a social media site is if the patient has specifically allowed or given you consent to do so. And when they're signing consent, it has to be specific to that they know that you will be posting this on a public forum, and it shouldn't have any identifiable factors as far as a patient's face unless they have specifically addressed that in the consent that they gave you. And finally, another don't is you should not allow patients, if you're using a computer screen and there's other patients' information on there, such as like a schedule that has what appointments that they're coming in for, Mrs. Jones should not see that Mr. Smith is coming in for a crown on number 3 next Tuesday. So you have to make sure that you have to hide or not put a computer screen in the area where another patient can see. So you'll learn a lot more about HIPAA in other classes, but it does apply to our class because it is involved in the paperwork that our patients do, and it's involved kind of with the medical history and disclosing medical history information. Alright, here is just a recap slide of how to properly and completely fill out a medical history and review it. You guys should be very familiar with this because we've done this several times in class. But as a review, if there are any yes responses, they're going to be circled in red, and those red circles are to alert you that they require follow-up questions. The patient will sign the medical history form in blue. You will sign the medical history form in black. Anything that you write in the medical history will be black. Anything that the patient has written will be in blue. Red medical alert stickers. If it's on the outside of the chart, you're going to have it in the upper right hand corner, and it's going to be blank. And then in the chart, you're going to have it in the upper right hand corner of the medical history form with the reason for the medical alert. So be it a condition, an allergy, a pre-med. And I'm going to give you guys a form of everything that's going to require that medical history, that medical alert sticker. All vital signs. Right after you complete the medical history, you're going to take your vital signs, and they're going to be taken and noted properly in the chart, and that's going to be on your assessments. And finally, all medications that the patient lists have to be looked up. You guys look them up in Lexicomp, and you're going to fill out that medication form each time the patient comes in for a recall appointment with you. We are now to the bottom side of the medical history form, and these last couple questions here allow the patient to address any conditions that are not listed on the form. So the form is pretty comprehensive, but there's a lot of things that are not listed on the form. So that gives an opportunity for the patient to disclose that. It also has it asks the patient about previous history of taking antibiotics prior to their dental treatment. So you might not think of a joint replacement as something that requires a pre-med, but if they mark that they have taken antibiotics prior to their appointments, that might be just another alert to you that this patient might be pre-medding for an artificial joint. When you're reviewing the medical history form, you're going to be asking follow-up questions, and that's going to give you responses. All of those responses need to be recorded on your medical history form somewhere. If they're not recorded, you didn't ask. So your instructor doesn't think you asked, and legally, you did not get the appropriate information that you needed to treat the patient. And finally, the most important part of the medical history form is the signatures. We need the signature of the patient, or if they're under the age of 18, a legal guardian, and we need your signature. Without these two, the medical history form is incomplete and it is not a legal document. So you need to have both signatures to make this document legal and to protect you from having a incomplete medical history, which could cause legal issues in the future. So If you do not have your signature on this when you complete your medical history form, your instructor will give you a big green X on your assessment form for that day. So this is very, very important that you have that signature right as you finish the form prior to calling your instructor over for a medical history check. And one final recap before we close out the semester is documentation. If nothing else, after medical history, you need to make sure you're properly documenting everything that occurred prior to the medical emergency, what happened during the medical emergency, and how did you resolve it, and what happened after the medical emergency. This is going to be written in your services rendered or your treatment notes, and it's going to be written as completely as possible. In this situation, you can't give too much information. You want to be as complete as possible. Nothing is insignificant. And a smart way to think about it is if you didn't write it, it didn't happen. So this documentation really covers you in the chance of any kind of litigation or legality if something happens to that patient. Thank you guys so much for a great semester. Your participation in class, your enthusiasm, your preparedness for taking all of my in-class quizzes before class starts. So I really appreciate it, and I'm looking forward to having you guys next year in class as well.